Thanks, Bob, and thanks, Marianne, for the invitation. I've been asked to talk about an overview of NETs and following your disease with blood biomarkers. So let's get started on that. Now, I realize that when you get any significant medical diagnosis, you are plunged into a state of sort of wondering, what does this mean? What does that mean? What's this term mean? What does it mean when the doctor says that versus that? Very confusing. So we're going to be talking about neuroendocrine tumors, but even that is super confusing. Look at all these things. Are they all the same? Neuroendocrine tumor, neuroendocrine cancer, neuroendocrine carcinoma, carcinoid tumor, carcinoid cancer, neuroendocrine neoplasm. Which one do I have, and does it matter? You know, it's human history. Things get discovered over time. Carcinoid tumor, 1907. Pathologist in Germany found that a patient who had died from tuberculosis had small little tumors in her bowel, looked like a carcinoma but didn't behave like a carcinoma, called it carcinoid tumor. 1929, the same pathologist figured out that carcinoid tumor could go to the liver. That was really a carcinoid cancer. In the 20th century, it became evident that where these carcinoid tumors were coming from, they were coming from rare cells called neuroendocrine cells within the bowel mainly, but elsewhere. And we started talking about neuroendocrine tumors. And that has a nice ring to it, NET. You know, a nice little acronym there. But even that, the purists feel that tumor is a vague term, so they prefer neuroendocrine neoplasm. You might find a NAN creeping in. The only one that's out of keeping here is NEC, and that's a neuroendocrine carcinoma, quite an aggressive tumor, and we'll see a little more about that. So neuroendocrine tumor, breaking up the neuroendocrine, there's the neuro and there's the endocrine. The endocrine system is a group of glands in the body, and these are some of them. They're quite visible. The thyroid is, each lobe of the thyroid there is about 1.5 inches by 1 inch. One would see it if one were doing, say, surgery or whatever. So quite visible. These tissues produce various hormones. Ovary produces estrogen, adrenal, adrenaline, et cetera, thyroid hormone. However, it's clear that there's more than just the visible endocrine system around, because over time it became clear that there are microscopic cells really throughout the whole body. You know, they're also in the thyroid, in the thymus, in the lung, in the stomach, everywhere in the body. There are these microscopic, what are called neuroendocrine cells. Some people call this the diffuse endocrine system rather than the endocrine system that's related to those big glands. So these neuroendocrine cells, they're pretty rare. This is a biopsy. So this is what a pathologist would look at if they had a colon biopsy. And all of the blue stuff here is usual colon cells and other structural cells. But if you look carefully, there are little red-brown cells here. You have to squint. Those ones are staining because they've got serotonin in them. They're neuroendocrine cells. Neuroendocrine cells, about 1 cell in every 100 in areas of the bowel. If we were to break out that neuroendocrine cell and give it an even higher magnification, it would look like this. There would be serotonin in it, which is the brown stuff, and the rest of the cell. So this is what a neuroendocrine cell looks like normally. And just to go over what's going on in those cells, so neuroendocrine cells, they have a neuro component. There are nerves coming into the cells. There are nerves between the cells. A lot of those cells within the stomach area and the intestinal tract are all nerved in together. There are blood vessels coming in. These cells are making various hormones and pushing those hormones out into the bloodstream. If I stacked up 2,500 of these, I'd have 1 inch, so pretty small. The other thing about a neuroendocrine cell, and we'll be mentioning this again, is that neuroendocrine cells almost uniquely in the body have on their surface little Velcro patches which are actually docking sites or parking sites for a hormone that can come in the bloodstream, a hormone called somatostatin. Somatostatin is a hormone that you've had from day one. Very important in growth and sort of the first 20 years. Not quite clear to me what it does for the next 40, 50, or 60 years, but it's there. And these cells are particularly sensitive to that, and we'll be mentioning it again. So, because neuroendocrine cells are anywhere in the body, you can basically get neuroendocrine tumors anywhere in the body. You can get neuroendocrine tumors anywhere. You see the green dots here. The size of the dot suggests how frequent it is. So the most frequent neuroendocrine tumors are probably in the intestine, but also a quarter to a fifth of them are in the lung, in the pancreas as well, a quarter or so. There's neuroendocrine tumors are basically a family of tumors, and this can be confusing as well, because in a family you have brothers and sisters, you have aunts and uncles, you have cousins, etc. Well, the brothers and sisters are the lung, gastrointestinal, pancreatic tumors. A lot of similarities between those tumors, and that's mostly what we're talking about today. Some of the cousins are the pheochromocytoma. This one and the paraganglioma, they are neuroendocrine tumors, but they make adrenaline, if they make anything. There's a special group in the thyroid, make a different chemical. There are some neuroendocrine tumors where we don't know where they come from. Some neuroendocrine tumors that are genetic. So, if you happen to have a neuroendocrine tumor that's a pheochromocytoma, and you go to Google and look up neuroendocrine tumors, you're going to be reading a lot about lung and pancreas tumors, because they are more commonly seen. So it can be troublesome for people who have the rarer cousins of the neuroendocrine tumors. So who gets a neuroendocrine tumor? Who can get a neuroendocrine tumor? Pretty much anyone, pretty much any time. Probably the peak is in the 50s, but 2/3 of people will get it between the 40s and 40 and 70. But we've certainly had children less than 10, 5% less than 30, 50. We've had people in their 70s and 80s being diagnosed with neuroendocrine tumor. We don't really know what causes it. No definite environmental factors. However, I should point out that recently the VA have accepted typical and atypical lung carcinoid tumors as being possibly associated with burn pits in Afghanistan and Middle Eastern combats. There are some neuroendocrine tumors that are genetic, but that is rare, and it's generally pretty easy to know the genetic ones because they come with multiple other tumors. But because particularly the pancreatic ones are genetic, we're doing genetic testing on many people with pancreatic tumors now. So how many people would get neuro? How frequent are these things? I think you've heard that they're pretty rare, but let me just show you some things about that. This is data from 2012. At that time, about 1.33 million people got a new diagnosis of any cancer in the United States. When I do, if my math is correct and going on 2012 populations, that would be 8,100 people in Nebraska. You see that cancers have been fairly stable, maybe even falling over the last decade or two, perhaps less cigarette smoking, other things. This, however, is what's happened to neuroendocrine tumors. It's a different scale here, so it goes from 1 person in 100,000 in the 1970s to 7 people in 100,000 in the 2010s. It's actually gone up to 8 people in 100,000 in our more recent numbers. So in Nebraska, if my math is correct, 2012, 126 new people were diagnosed with neuroendocrine tumor. If you think about how many people, however, are living with neuroendocrine tumors, again, 2012, 150,000 people in the United States, 900 people in Nebraska with these tumors. And that turns out to be more people than are living with stomach cancer and pancreas carcinoma, because although stomach carcinoma and pancreas carcinoma are much more frequent, people die much quicker, and therefore they don't live as long, and therefore the less of those people living with those cancers. So this is, I'm going to talk about some milestones. These are sort of medical milestones, I suppose, in relationship to neuroendocrine tumors. And there's it's easy for me to write down medical milestones here, and it looks pretty simple, but I understand that there's a lot of pain and there's a lot of time that goes between each of these medical milestones. But I am going to wrap the rest of my talk around some aspects of each of these milestones: how people present, how people are diagnosed, what sort of therapy they get, what sort of follow-up they get. So how do people present? What do people come in with? Well, this is a study of a few hundred people with various different small bowel, pancreas, and other neuroendocrine tumors. Let's just focus on the black stuff, which is the small bowel. So 40% of them, their first symptom was abdominal pain. That's why they came into the clinic. Another group came into the clinic they had incidental finding. It was found on a colonoscopy that they had for some other reason, or they were involved in a motor vehicle accident and had a CT scan, and boof, there it is. And then about 25% actually came in because of what we would call carcinoid syndrome, which is the presence of diarrhea or flushing. Another interesting thing from this study was how long some people spend with their symptoms before they get diagnosed. So again, this is just the small bowel group. Most people got their diagnosis. The average was 2 or 3 months between symptoms and diagnosis. But 20% of the people here took longer than a year, and 5% of the people here took longer than 5 years to get their diagnosis. Rare disease, not a lot of physicians know about it. Some of the symptoms can look like other things. There are lots of reasons. So, actually, we'll go on to the next one. What are the symptoms of a neuroendocrine tumor? Well, we can have no symptoms at all. That's the people who have had their colonoscopy because they turned 50 years old and found a tumor. We can have a group who have symptoms due to the mass of the tumor, due to a mass in their bowel which is causing pain, or bowel obstruction or bleeding, or due to a mass in their lung which is causing coughing and bleeding. That's what we sometimes refer to as non-functional tumors. This is another term that you sometimes hear. And you have a group of people who will come in because their tumor is quote-unquote functional, and that means that it's making hormones, and that these are causing what are called the carcinoid syndrome or some other syndrome. Carcinoid syndrome is one of the most common syndromes associated with neuroendocrine tumors, and causes diarrhea and flushing. This is one of these terms that again is really confusing, because do I have a functional tumor? Do I have a non-functional tumor? And indeed, does it matter? Functional tumors are ones where the tumors are making hormones, and those hormones are causing specific symptoms. Now, why they decided to call that a functional tumor? What's the function of flushing or diarrhea? I don't know, but they called it functional tumors. But non-functional tumors then don't have those particular symptoms. They may have symptoms of blockage of the bowel because of the size of the tumor. The non-functional tumors, what makes it more complicated is The pathologist may look at that tumor and say, yes, there's serotonin in that tumor. That doesn't make it a functional tumor because it doesn't have symptoms. It's even more complicated in that you can measure the serotonin that's coming out from the tumor, say in the blood test, but if it's not high enough in the blood, it won't cause symptoms. And indeed, there are many people who have very high levels of serotonin in the bloodstream, don't have any diarrhea or flushing. The functional tumors are a minority of tumors, but they are important. So diagnosing with people with NET, as we mentioned, symptoms, some imaging, some lab tests, biopsy. Let me just give some brief discussion about some of these things. So glad that Marianne has already taken Octrio scan off the table. This was a great scan in the 1980s, but should be shelved because we now have gallium and copper dotatate PET scans, which you'll hear more about. We have CT scans, we have MRI scans, and sometimes it's very confusing about why the doctor chooses one scan and not the other scan. And this be difficult to read from the back of the room because there are lots of reasons. The CT scan is the workhorse scan. It's very easily available, so it's the initial scan for many people. It's very good for establishing the extent, how far the tumor has spread, which is what we call the staging. It's very good for surgeons. It tells them exactly where tumors are in relationship to blood vessels and other important structures. It's good at finding a primary tumor when it's not evident. It's better than MRI scans for lung and in the lower abdomen. However, the other thing about CT scans is, and you'll see this if you ever read any of your CT scan reports, neuroendocrine tumors enhance when the contrast goes through the neuroendocrine tumor. What does that mean? This comes from a paper by Dr. Howe and a previous trainee of his who's now at MD Anderson. Enhancement means that shortly after, within 1 minute of the injection, that intravenous contrast is shooting through the liver, and all of the whiteness that you see here, the white blobs here, are tumors that are enhancing. This person has a lot of tumor in their liver. If we wait another 60 seconds, it doesn't look like as much tumor at all. And indeed, if we wait for another couple of minutes, it doesn't look like there's any tumor there at all. What I mean to say here is that CT scan is only as good as the protocol that they use. If the correct protocol, triple phase, 3 phases, early, shortly after that, and later, if that's not done, CT scan won't be a very good scan. CT scan does have radiation, can't use it with poor kidney function. It's not so good at looking at bone. MRI scan, much better for the liver, good for pancreas, but not so good in the lower abdomen for smaller lymph nodes. It doesn't have any radiation, which is good, but it's uncomfortable, it's slow, it's noisy, it's more expensive than a CT scan, and therefore can be difficult to get through insurance. Sometimes the medical decision-making is insurance decision-making, unfortunately. And that, we'll hear more about gallium and dotatate PET scans, but insurance becomes a big issue with gallium and dotatate PET scans, which have great advantages. A whole body scan can tell us if a person is likely to respond to PRRT or sandostatin, but can have expense issues. Biopsies. This is what a pathologist would see on the biopsy. They can tell whether the tumors are well differentiated, behaving like normal cells, or whether they're poorly differentiated, look more aggressive. The pathologist will do multiple stainings to figure out, is this a neuroendocrine tumor? Where does the neuroendocrine tumor come from? You'll see on your pathology report a statement about Ki67, which tells us how many of these tumor cells are actually dividing, how many of them are behaving like cancer at the time that this biopsy was taken. And that's very important in establishing the grade. Some places we like to do a stain for the somatostatin receptor. Anything that's brown here means that there's somatostatin receptor, which tells us that these cells will be sensitive to monthly injections, will be sensitive to octreotide. So we established the grade, or how aggressive the tumor looks on biopsy. This is something that the pathologist will tell us. And the grade really makes a difference. The grade is mainly dependent on how many cells are actually dividing, and that's what we get from the Ki67, because grade 1 and 2 have pretty slow growth, and they're sensitive to somatostatin analogs, the monthly injections, or PRRT, radioactive somatostatin. Whereas once you get to grade 3, there may be some difficulty with sensitivity there. And once you get to the poorly differentiated grade 3, which was the one that I mentioned on the first slide, neuroendocrine carcinoma, more aggressive, needs chemotherapy. Another confusing factor with pancreas and bowel tumors, they talk about grade 1, 2, and 3. With lung tumors, the pathologists can't quite sort of get it together. So they talk about typical and atypical. I was never very sure what's typical about a typical carcinoid, except that it's a little more typical than an atypical carcinoid. But if you think of typical as sort of approximately grade 1 and approximately grade 2, so well differentiated, that would be reasonable. Some things about a biopsy. Getting the initial biopsy right is very important. If you get off on the wrong foot by mistaking a neuroendocrine tumor for a different neuroendocrine tumor, say a paraganglioma, you go off on a wrong trail for therapy. You can mistake a carcinoma, much more aggressive, like a colon carcinoma, for a neuroendocrine tumor and get put on chemotherapy for the carcinoma, which is entirely doesn't work for a neuroendocrine tumor. So second opinions, expert opinions on pathology are important. Rebiopsy is an occasional thing because grade sometimes changes over time. And so we sometimes need to do additional biopsies and special stainings. We can tell frequently where the tumor comes from, whether it's from the bowel or from the pancreas or lung, with those special stainings. Does size matter? Size does matter. There are many tumors that where really, depending on the size of the tumor, we can determine how risky it is. So many people have their routine colonoscopy. They're found to have small neuroendocrine tumor in the rectum, or small neuroendocrine tumor in the stomach. If it's less than 1 centimeter, it's unlikely to cause problems. They just need it removed, and that's about it. At least that's what the recommendations are. More than 2 centimeters, there can be problems, and that goes for pancreas as well. And that sometimes drives our therapy. So the size does matter. I've mentioned on a number of occasions the issue of the origin of the tumor. Does it matter where the tumors come from? I've described these tumors as brothers and sisters, as opposed to the cousins, which are the pheochromocytomas. Well, yes, it does matter where it comes from, because the FDA-approved therapies, PRRT is an FDA-approved therapy for pancreas and intestine. Now, we frequently do PRRT with lung, but until the trials come out, it may not receive its FDA approval for that. Different tumors are somewhat they have somewhat different sensitivity to chemotherapy. And most importantly, I think, different tumors can have different amounts of the somatostatin receptor and therefore different sensitivities to the monthly injections or to the PRRT. Lung tumors have significantly less sensitivity in some tumors to monthly injection or PRRT. And the different tumors make different chemicals, and therefore they have different syndromes associated with them. So the main carcinoid syndrome is associated mostly, but not entirely, with small bowel neuroendocrine tumors. Lung neuroendocrine tumors can make histamine. They can give almost an allergic reaction. Pancreas neuroendocrine tumors can make a bunch of things, including insulin, cause you to have low blood sugar. So, all of these issues, the size, the stage, the grade, they all influence overall survival. I don't need you to look at the numbers for overall survival. I want you to look at the pattern, because this comes from 2012 and before, and that becomes very important, as I will show you. But the pattern is the same. If you have tumor that's very localized, people do better than if they have tumor that's gone into the lymph nodes or that's gone into the liver. If people have tumor that has a low grade, a low aggressiveness, they live longer than people who have high grade tumor. So, getting to carcinoid tumor markers. Carcinoid tumor markers can be, again, somewhat controversial. Many times physicians don't quite agree on what they all mean. And that's, there are many studies, but they're smaller studies, so there can be a lot of issues with them. I find them helpful, and I'll outline some of that. So neuroendocrine tumors, they make chemicals, the whole bunch of them, more than 20 of them. We can measure these chemicals in the bloodstream or the urine, and that tells us something about the behavior of the tumor. Higher levels of those chemicals, higher aggressiveness of the tumor. Some of those chemicals, like serotonin, they actually cause symptoms. Others, people can have chromogranins that are 100-fold elevated and don't have symptoms because of the chromogranin. They may have symptoms because of the size of the tumor. Different tumors make different chemicals. These chemicals can be good they can be good to some extent for diagnosis, but they're mainly helpful in figuring out progression. The tumor markers can change before the CT scan changes. The tumor markers can get better after PRRT before the CT scan changes. So they give us a head start on some of the changes and warn us that we may not be seeing something in the CT scan, which is our usual scan. But the tumors, there are relatively few labs that measure these tumor markers, and it's super important to get the tumor markers measured in the same lab each time, because otherwise it's difficult to compare them. There are tumors that don't produce any, and all of these tumor markers can be falsely elevated or falsely low. So I mentioned that different tumors make different tumor markers. Again, the small intestine, serotonin is a big one. Chromogranin is there. Lung neuroendocrine tumors, chromogranin is there. Pancreas neuroendocrine tumors, chromogranin is there. And some other things. Pancreas neuroendocrine tumors, some of them that are functional, some of them make insulin or a variety of other chemicals. So let's talk about some of these common tumor markers. So serotonin, Serotonin is produced by these tumors, many of these tumors, especially the bowel tumors. It gets broken down in the liver to a thing called 5-HIAA. So serotonin and 5-HIAA are sort of used interchangeably because they are directly related. And you can measure in the blood, or you can measure in the urine. They're pretty specific for carcinoid syndrome. Serotonin, as we'll see in the next talk, really is the driver of a lot of the diarrhea and bowel issues that occur in carcinoid syndrome. The different tumors again make different amounts of this. So again, the small bowel is the main site for serotonin. The blood tests are certainly less cumbersome than a 24-hour urine, but they can be more variable if they're not done carefully. The 24-hour urine, which has been around for the longest, really requires very close supervision of diet to make sure that a person is not taking in things that will be turned into serotonin. So that's the diet consists of, there are many nuts and fruits and some vegetables and there are many drugs that interfere with this. So there's a long to-do list for 3 days to get an accurate urine test. The blood tests do have some effect of diet, but much less than this. The level of elevation of these things is important. Very elevated serotonin or HIAA really suggests that a person might have tumors in their liver. Generally, that's what it suggests. We'll talk about that more in the next talk. Very elevated 5-HIAA levels or serotonin levels is a big risk for carcinoid heart disease, which we will talk about some more. Chromogranin, it crops up in all of the neuroendocrine tumors, and the amount of chromogranin that's there really reflects how much tumor is there. This one, again, it's very important to get it measured in the same lab each time. There are a lot of false positives with this. In fact, chromogranin probably has the most false positives of any of the tumor markers, I think, because chromogranin is affected by medications that lower stomach acid. So your Prilosec, your omeprazole, all of the medications like that are going to put up chromogranin and don't mean that there's a tumor there. It also goes up with poor kidney function. But in a person who has been diagnosed, it can be helpful to follow up a confirmed diagnosis. So not to use it as an initial diagnosis, but to follow up a confirmed diagnosis. To try and get away from some of the problems of chromogranin, Pancreastatin was discovered and developed as an assay. This is a patient that my late colleague Dr. Odorizio published a paper on, along with many other folks. I can't remember if Gene Waltering, he probably was on this paper as well from New Orleans. This patient had a surgery, pancreastatin went down nicely, but then as the tumor grew up again, the pancreastatin went up. In this patient, the serotonin didn't go up, the chromogranin didn't go up. In fact, it was the pancreastatin and only the pancreastatin that was a marker here. A couple of things about pancreastatin. It seems to suggest that there's tumor in the liver. Very high levels is a poor prognosis. It's not affected by the stomach acid issues, but it does have. There are things that can affect pancreastatin. Pancreastatin, more than many of the tumor markers, I recommend specific laboratories for pancreastatin. There's one laboratory on the East Coast where, I see many patients coming to me with high pancreastatin levels, because they get it tested at Bioagiletics. I can't find any tumor. I repeat the pancreastatin in another laboratory in California. It is normal. So I really recommend not using, and there are even papers in the medical literature about that one. Some tumor markers, they can really tell whether a person has aggressive cancer or not. So people who have neurokinin of more than 50, this is a life curve. You can see that the duration of survival with the neurokinin over 50 is much decreased from a neurokinin of over 50. And it tells us that we need to be much more aggressive in terms of the treatment. So tumor markers are a work in progress. A lot of new stuff coming up about tumor markers. The tumor markers that I've told you about are all single chemicals that come from neuroendocrine tumors. Where the cancer field is going is to look at multiple genes that might be coming from tumors, or tumor cells that might be breaking off tumors that we can capture in the bloodstream. One of these tests, which measures 51 different pieces of genetic material, is called the NET test. And while it's not currently recommended by the major organizations, there's increasing evidence to support its use as a tumor marker. So one thing about therapy, we'll be hearing other talks about the various forms of therapy, surgery, monthly injections, PRRT, drug therapies, liver-directed therapy. One thing that I want to point out to you, and it's something that Dr. Maluccio mentioned, was that when you look at this group of treatments, one thing that's really important to remember is that these ones are new since 2011. These gallium PET scans, copper PET scans, Somatuline or lanreotide, Zermelo, Telotrestat that we'll talk about, PRRT itself, although it's been used in Europe since the 1980s, and certain centers in the country have used it in clinical trials for a few decades. It's only FDA approved recently, and many of these drug therapies have either started to be used or been FDA approved since 2011, and that's why I think that those survival curves will change. That's in the last 10 years. Progress doesn't stop. There are lots of clinical trials for new drugs. There's real excitement with certain drugs. There's real excitement with new forms of PRRT that you'll hear about this afternoon, and I think you'll gather some of the excitement. So don't forget to, when there is a discussion about changing therapy, to ask about these things. Follow up, how do we follow up? Well, we follow up with very, very much the same things that we diagnosed in the first place. Symptoms, imaging, tests, lab tests. So thinking about your own tumor, I hope that you know what the site of origin is, because it's important, the size, the stage, which is how extensive it is, how much it's spread, the grade, the hormone production, whether it's functional or non-functional, because all of these things affect the treatment going forward. I think there'll be some really good talks, I hope, for the rest of the day about flesh out some of the details here. But otherwise, with 45 seconds to go, I will leave you at that. Thanks, and this is our group at Iowa. Many of you are patients there. Thank you for coming all the way. Thank you.